Good afternoon and welcome to the March Idaho Clinicians for Climate and Health and St. Luke's Climate and Health Learning Series. Today, we are fortunate to have two exciting speakers from the pediatric infectious disease world. We're going to talk a little bit about the emergence of infectious disease and the setting of climate change, and a lot about how we can use antibiotic stewardship to better reduce our climate impact of the care we provide without compromising the care we provide. So I'll introduce our speakers in just a moment, but prior to that, I wanted to give you a few reminders. First, if you've got questions, please put them in the Q&A tab, and at the end of their presentation, I'll moderate some questions with the speakers, so please use the Q&A tab for that. Second, we've got a couple of other talks coming up in March. This is the March one. Obviously, April, Leo Tresand from NYU Langone School of Medicine will be here to talk about plastics and health. This will be an opportunity to have an in-person event, but you can still attend virtually if you're not in Boise. So we will have Dr. Tresand speaking at the Pediatric Grand Rounds at St. Luke's Children's Pavilion on Wednesday, April 8th at noon about plastics and health. And then in May, we will have a talk about the Canadian Choosing Wisely guidelines and how we can use those to reduce our carbon footprints. Also, we'll have a post-lecture survey. So if you can make sure you check your email after the lecture today and let us know your thoughts on how we can improve things. As has been the case the past couple of years, we'll take June and July off, and then we'll be back in August with the fall and winter series. So with that, I'd like to introduce our two speakers for today. The first is Dr. Preeti Jaggi. Preeti is the Director of Antimicrobial Stewardship at Children's Healthcare in Atlanta. She graduated from medical school at The Ohio State University and completed her pediatric residency at Loyola University Medical Center and her infectious disease fellowship at Northwestern University in Chicago. And just received some national recognition from the Medical Society Consortium for the outstanding work that she and her organization, Sustainabil-ID, did in their local political environment. So big congrats to Preeti on that. And Shreya Doshi is an attending physician in pediatric infectious disease at Children's National Hospital and an assistant professor of pediatrics at George Washington University School of Medicine and Health Sciences. Her research efforts focus on integrating environmental stewardship into pediatric practice to enhance patient outcomes and protect public health. Dr. Doshi completed her fellowship in PEDS-ID at Children's National and holds a Master's of Public Health in Global and Environmental Health from George Washington University's Milken Institute of Public Health. I have to say I've seen both these women speak before, and it is an outstanding talk, and I've had the wonderful opportunity to meet them in person, and they're just lovely people. So I'm excited to introduce you all to Drs. Jaggi and Doshi, and I'll turn it over to you guys now.
Sorry about that. I was still on mute. Thank you for having us. I will start us off. We'll talk a little bit about infectious diseases and climate change, and we'll talk about antimicrobial stewardship as kind of a template for how we can start implementing healthcare sustainability into the infectious disease management and prevention aspects of what we do. And then we'll talk a little bit about using quality improvement frameworks to calculate environmental savings of existing work. So the idea of One Health actually came from observation in the 1800s of animals and humans being able to be infected by the same organism. And we kind of expanded the topic of One Health to be integration and interconnection between human health, animal health, and now adding in our shared ecosystems, the environmental health, because we all depend on clean air and water to thrive. And so we're going to talk a little bit about this as it relates to infectious diseases. Next slide. So you can actually think about over half of known human pathogenic diseases can be aggravated by climate change. Some of the ways that this could happen, like when we have standing water after a big, huge rain dump that occurs more with warming worlds, that standing water can breed mosquitoes, which can then cause infection like malaria. And we also think about our vectors also moving like with Lyme disease. We also think about a lot of diarrheal illnesses after really extreme weather as well, like storms. And I'll show you a couple of examples that have been highlighted by the European Society of Pediatric Infectious Disease, and in children in particular. And the things that they highlighted is that about 1 in 4,000 children die from air pollution associated lower respiratory infections. So thinking about community-acquired pneumonia. Over 1 in 4 children are exposed to vector-borne diseases like malaria and dengue. I heard a really recent talk about how dengue is actually really increasing in the Western Hemisphere. And then diseases like Zika and Ebola are linked to biodiversity loss. And then again, diarrheal illnesses. Some nice studies have come out that show that diarrheal illnesses are worse after extreme precipitation. You can go to the next slide. And we did actually a study a few years ago. We just asked some of our pediatric infectious disease providers throughout the country, what are the things that they have actually observed? Some people mentioned, seeing Lyme disease in Tennessee, where they really hadn't seen that before, and Missouri. Increases in the severity of some infections like coccidioidomycosis in the West. More asthma exacerbations, which sometimes leads to unnecessary antibiotics because people can't really necessarily distinguish between bacterial pneumonia and asthma, or asthmonia as they call it. And then other people said that they were noticing some unusual infections like Mycobacterium marinum along the upper eastern seaboard. People seeing cases of cutaneous leishmaniasis from less classically endemic places as well. So these were just kind of the anecdotal observations of pediatric infectious disease providers throughout the country. You can go to the next slide. Can you advance one?
So it is advanced on my end. Maybe I'm not sure what's. Can you see it advanced now, Dr. Jaggi?
I do not see it advanced.
What about Ethan? Can you see it advanced, or which slide are you seeing, Ethan?
Still on the anecdote slide.
Oh, it's advancing on my end. Can I reshare my screen?
Yep.
Okay, sorry about that.
No problem.
It wouldn't be a lecture without an IT issue.
Resharing in just a second. Can you guys see the stewardship and sustainability slide now?
Yep.
Yes.
Okay.
So we are thinking, a lot of us in infectious disease have been working with, oh, I think I just lost it one more time. There we go. Have been working with this idea of stewardship around antibiotics, and that term was coined in 1996, saying that we need to use our antibiotics wisely. And I think a really good example of that is Alexander Fleming's quote, that is, the thoughtless playing with penicillin leads to penicillin resistant organisms that can go from person to person. So it's very, very specific. When I think about sustainability, I think about it a broader aspect, not just antibiotics, but what are all the resources we need to make certain things and to dispose of them. So more along the lines of making your decisions on behalf of the 7 generations coming so that they may enjoy what you have today. And so we've kind of really taken what we do in stewardship and expanded it to sustainability. You can go to the next slide. I don't see it. Oh, there we go. Yeah, there we go. And there are some studies that look at the environmental impacts of health pollution basically from the healthcare delivery system. And Matthew Eckelman has done a lot of these studies. And he did a paper a few years ago that said that disability adjusted life years from deaths due to preventable medical errors are on the same order of magnitude as those lost due to healthcare related emissions. So he's asking for a similar calling to national attention to prevent healthcare pollution. You can go to the next slide. So as some of you may know, we have different scopes of our emissions. So let's look at the clouds first. So those are the greenhouse gas emissions. It's not just carbon dioxide, but also methane that can occur from landfill waste, for example, and then our fluorocarbons that we use in our anesthetics as well. And so things like anesthetics are considered a scope 1 emission from your facility itself. Scope 2 is things like electricity that you purchase to power your facility. And then scope 3 is the vast majority. And this includes all of the other things that we do: staff commuting, our medications, food and catering, travel for employees, waste, our solid waste generation. And the biggest single chunk are the goods, services, and supplies that we use. And then we can also impact something that's considered out of our scope, but that is patient travel to our facilities as well. You can go to the next slide. So just a couple of key definitions. When we think about a life cycle analysis, that's a really rigorous method to evaluate the entire environmental impact from creating that product, using it, and then disposing of it. So it really helps us do a really comprehensive analysis. In my practical ways of doing this, sometimes I don't think I can do a full life cycle analysis, so I just weigh my products and look at the disposal part of it. And then, of course, greenhouse gas emissions are gases such as carbon dioxide, methane, and then our anesthetic gases. And then typically when we talk, we're going to talk about carbon dioxide equivalents. So that's kind of the unit that we use to measure greenhouse gases to make it comparable with the other greenhouse gases. So I think the mitigation solutions is where we can really be creative and have fun. And we've been really kind of thinking about this in the context of infectious disease management because the problem is really, really big. So let's go to the next slide. The way that I usually think about things is this mnemonic that the Providence Health System uses, which is we act. So W, decreasing solid waste, E, energy and water, and that might be really especially important on the west coast of the country. A for anesthetics and anything along the agriculture or food cycle. C for chemicals, pharmaceuticals, and medical supplies. That's going to be the biggest single chunk of our greenhouse gases. And then T for transportation and including telemedicine. You can go to the next slide. So when we think about antimicrobial stewardship, we're starting to think about everything with the antimicrobial drug, not just the drug itself. For a while, we were just thinking about the drug itself, or we would say, okay, we were saving days of therapy of an antibiotic, and we can safely do that. But now we've kind of we're looking at more that we can save from that. Go to the next slide. So just for anyone that's not familiar, one of the things that we've come up with in the infectious disease antibiotic stewardship framework is to think about the 4 moments of antibiotic decision making. So 1, making a correct diagnosis. 2, culturing and using the appropriate empiric therapy. 3, stopping, narrowing, and changing to oral wherever possible. And then 4, looking at the safest duration of treatment, safest minimal duration of treatment. So I would say there are a lot of studies that are coming out on duration especially, and that's kind of a constantly changing field. One of the big trials that came out fairly recently was the BALANCE trial, which looked at adults with gram-negative rod bacteremia, and they looked at 7 versus 14 days of treatment, and they actually found that it was non-inferior to use 7 days of antimicrobial treatment in those patients. So that was just an example of the studies that come out looking at safest minimal duration. So as a stewardship program, we kind of work on these all the time. So we'll show you a little bit of the environmental savings of that as well. It is really important to note that IV drugs, you can go to the next slide, Shreya. The IV drugs have a lot more solid waste generation versus doing an enteral drug. So on the right is a study in Brazil, and they just did IV to oral conversion for a 3 times a day medication, and they saved 4.8 kilograms of weight per day just by doing that. And then, of course, if you save hospital days, that's also going to save a lot of solid waste as well. That's the amount of kilograms on the left that you save from saving an inpatient stay on a floor for a patient in New York City. So just keeping the patients out of the hospital, which we all want to do, and then oral conversion is a really great idea. You can go to the next slide. So in the UK, they actually talk about sustainable healthcare value, which is the best clinical outcomes with the least social, environmental, and financial harms. So if we went from ampicillin to amoxicillin for a child with pneumonia, the ampicillin is given 4 times a day for children with pneumonia. And so we save actually at least 20 minutes of healthcare worker time to make that medication and give that patient the medication. We know we need the flush actually to give the medication, and it's cheaper to give that drug orally. And then I also actually noted from just following along some nurses and just shadowing them is that if the patient's in contact precautions, they're also using a lot more gowns and gloves because they have to go in, give the medication, then they typically leave, they go in again and start the flush, then they leave, and then they go in again. And so if they may actually require 3 times the amount of personal protective equipment for certain patients as well. You can go to the next slide. And we actually did some surveys of our outpatient community pharmacists around the most commonly prescribed drug that we have, which is amoxicillin. And we actually just asked them about amoxicillin waste, about the drug waste itself. And one of the things that they said, which I thought was pretty interesting, one is they really didn't like the computerized dosing algorithms, which give very odd amounts of doses, like maybe 7.2 milliliters of amoxicillin twice a day. They don't have the ability to up or down round for those drugs. And then they also noted that some of us write a little bit of an extra of the liquid in case it spills or something like that. And so they saw that will maybe necessitate them using an extra bottle because those bottles come in very specific sizes. You can go to the next slide. So they oftentimes noted that this was a problem. And we know with liquid formulations, we have to use, if we give an unnecessary drug, we know we have unnecessary plastic waste and paper waste. So good antibiotic stewardship is really, really important. And, we need energy to make the drug. And then if we give a liquid drug, you need to give a dose dispensing device. So that's a little bit of extra plastic. And we also know that if we have to give a little of an extra amoxicillin to families, that some of it may end up in the environment, down the sink or in the trash, and that may end up in the environment. So one of the things that we did at our hospital was we just did an experiment of how many doses we were giving of 3 drugs, Tylenol and ibuprofen, and then liquid amoxicillin. And we only looked 2 and above because we can give chewable tablets to kids 2 and above. There's not an aspiration risk at that age, but we can't do it for babies. And we noted that we were giving 86,000 doses of acetaminophen, 74,000 doses of ibuprofen, and 11,000 doses of amoxicillin in this age group. And we noted that the vast majority was given as a liquid instead of a chewable tab. And if we would have chosen to use those chewable tabs, we would have saved 382 kilograms of plastic waste. So this is just a formulation change. And really, we looked at the cost as well. And the cost, you have to also pay for the syringes. And so it's actually cheaper to do this as well, at least it is for the acetaminophen and ibuprofen, which were the vast majority of the drugs we were giving. You can go to the next slide. So when I also think about antibiotics now, I do think about the multiple times of a day of a drug versus a single day dose. If I just think from an antibiotic stewardship standpoint, I might say, oh, well, ceftriaxone is a broader drug than ampicillin, which is true, and that can have some harms like resistance. But also we have pharmacy prep time and nursing time and plastic syringes and plastic flushes and EVS workload. So I started kind of thinking about a lot of these things. The best thing, in my opinion, is to get the patient on an oral drug whenever possible. That's the best solution, I think, there. You can go to the next slide. So we did this study a quality improvement work that we did in our hospital for community-acquired pneumonia. We used an order set, and it just gave the kids about 24 hours of ampicillin, and then it automatically switched them to amoxicillin because that gave the provider about 24 hours to observe if the child would be able to take the medication. And it was kind of, you're opted into that methodology, and then you have to opt out of it if you don't want that. But before it was a little bit harder to do that, and it wasn't automatic. And you can see our enteral conversion went way up just by using this order set. And then one of the things that we also noted, actually, on the next slide, is that we decreased a lot of ampicillin wasted doses. These are doses that, because it is given so frequently during the day, oftentimes if the pharmacy just doesn't know what you're going to be doing, and so they make the drug before you actually are going to use it because they batch process these drugs. And so just by giving them the heads up with this, we also decreased significantly the ampicillin wasted doses. And you can see in the orange was ampicillin sulbactam, which stayed about the same because we weren't doing anything with that. You can go to the next slide. So the other thing that we should think about is IV fluids. We know that IV fluids are associated with peripheral IV extravasation. They could potentially be associated with CLABSI. And we also use these bags, which cost money. And during the shortage during Hurricane Helene, because of the Baxter plant, which was just sort of decimated by that hurricane, we had a very significant fluid shortage. I don't know if you all experienced that in some of the areas that you're coming from, but we definitely experienced that. So we actually started saving about 50 bags a day because we started using fluids more judiciously. So that saves money. And also that saves greenhouse gases as well. You can go to the next slide. There are the plastic itself, of course, requires fossil fuels. This is just, the amount of fossil fuels you need to make a plastic bottle and to transport it into market. And then the bag for the IV also requires fossil fuels to make it. So you're saving that as well. You can go to the next slide. This is a life cycle analysis that was done on a European product. And it's not exactly the same, but they actually did a full life cycle analysis. So they were looking at the energy needed to make and produce the material, to distribute it to hospitals, and then to do an end-of-life treatment of that. And they looked at 3 different scenarios: recycling, landfill, and incineration. And you can go to the next slide. They actually noted the biggest part of the greenhouse gas footprint was the packaging. So this is for a 500 ml product, and even probably for a liter, it would probably be pretty similar because most of it's just the packaging of the material. And then actually the tertiary packaging of putting it into a landfill was also high. And so you could see, like, just by what we were doing when the Baxter plant closed, was that we were saving just about the equivalent of 1,000 gallons of gasoline a year just by using those fluids more judiciously. And unfortunately, once that went away, we started backtracked and kind of went back up using our fluids again a little bit more. So in general, when I think about starting, especially when it comes to ID things, with infection prevention especially, you want to really look at areas where you can have a cost savings, you can decrease your environmental impact, and you can either improve or have the least impact to patient care and workflow. That's where I would start. We are doing a project right now. We throw away pillows in our hospital every day. So we're working on a project about getting a pillow that is wipeable, and they are going to use the same wipe that they use for the mattress. So we're trying to make it least impact to patient care. Other hospitals have done this, so it's not something that hasn't been done. And we're kind of, because we think that you can have a cost savings, decreasing environmental impact, and actually be pretty easy for the workflow. So that's where I would kind of start with these kind of projects. And then also, I just wanted to show you these ladders, because the ladders show small steps can actually get you to the same spot as taking big steps. And I think sometimes we think we have to do bigger steps than we maybe should be. In antibiotic stewardship, we really started with small little steps, and it really got us far over time. So that's the other thing I would just say, is that no system change is too small. Anything you can start with, and that's still valuable. Thanks so much. And I'm going to pass it along to Dr. Doshi.
Thanks so much, Dr. Jaggi. We really like to get samples in infectious diseases so that we can do targeted therapy. And I really like this meme because we're always looking for what we call source control. So if you have large abscesses, for example, we know that antibiotics alone are not going to be very helpful because for a large abscess, you need to get the pus out. So I think of healthcare sustainability as a way of doing source control for all this waste we have in healthcare. And like Dr. Jaggi said, it brings a lot of joy to a lot of people when you work on these projects together. So I'm going to talk a little more about other areas and then QI and how sustainability is impacting how we recruit trainees in ID as well towards the end of the lecture. So one thing that I had been working on throughout my fellowship was a project on antibiotic waste at my hospital. And just to explain that at most hospitals, after you put in an order, the pharmacy is generally preparing scheduled orders 4 to 5 hours in advance. For the stat orders, they have a different workflow. But for somebody who's, let's say, scheduled to get a ceftriaxone today at 5 p.m., if I put in an order, they've probably already prepared it 4 to 5 hours in advance. And then when I cancel it though, and sometimes, I want to narrow the therapy and it's a good thing. So let's say I want to switch from ceftriaxone to ampicillin. My intention is good, but as a clinician, a lot of times I'm not aware that the ceftriaxone that I've already written for is probably going to waste because they've already prepared it for a specific dose in pediatrics. So we do weight-based dosing. So then that goes to waste and either gets autoclaved or incinerated based on what your hospital does. And I think that batch processing is interesting. We really use it here in most hospitals from, the people I've spoken to in our community. But I'm not sure if other countries use it. So for example, maybe in some European countries and Australia, they do some of these preparations at bedside. So they don't have this waste necessarily. So we're looking more into this and how practices vary. But at least from the 4 hospitals that have published on this, we know that we are wasting a lot of doses in the thousands, as you see here, per year. And then the additional cost, not just from the cost of the drug itself, but also the incineration cost. All hospitals are paying a hefty fee to transport this waste to their incinerating center, the cost from the fluids that go with it, the syringes, the saline. A lot of this waste is happening around discharge. And, this is a very interesting area of research, and we hope to continue to investigate this more and then expand what we learn from antibiotic waste to all medication waste. So really, when we think of these meds, we should also think about the drug shortages. A lot of times, because the drug shortage, we are substituting a drug that is a standard of care treatment with a less preferable treatment. And our waste is contributing to these drug shortages because these are unexpired drugs that are getting wasted because of batch processing. And then there are a lot of other disadvantages. So they can seep into the environment, the nursing administration time with IV drugs, length of stay, etc. There's a lot of things to consider in a holistic way. So some of the projects that I want to highlight are just examples as to what you or your trainees could do in this area. So for example, this project done by some of our colleagues in Utah, they calculated the greenhouse gas emissions due to unnecessary antibiotic prescriptions. So just by weighing the paper and the plastic bottle that comes with each prescription, and it was equal to about 4.8 million miles driven, or circling the earth around 194 times. So that's the impact of our emissions from unnecessary prescriptions alone. And they did that by weighing the paper and the plastic and then using some EPA emission factors. And for the prescription data, they used the CDC data. Pam Lee from UCLA Harbor has come up with this wonderful calculator that lets you compare antimicrobial regimens. So I can actually compare, let's say, if I were to do 10 days or 5 days of ampicillin for community acquired pneumonia versus amoxicillin, if the patient's able to take PO, you can compare the waste from both the regimens. And that's like a really interesting way to think about this and advocate for more IV to oral conversion. We also want to talk a little bit about quality and safety, because really sustainability and quality safety align very well, because it helps prevent harmful emissions, and that's our goal, right? We want the whole population to be healthy. So by minimizing environmental pollution, we are helping providing high quality care, and it helps make the supply chain more resilient. So, for example, with the examples Dr. Jaggi gave about IV fluid shortage, what if we thought about using our resources judiciously from the get go, not waiting for a hurricane to happen or a supply chain shortage to happen? What if we use them very carefully with a dashboard, with measures in place to make sure we're keeping our waste under check at all times? And then, of course, it improves quality because it elevates the overall standard of care. You're using your resources wisely, you're doing cost efficiency, helping with patient equity and safety across healthcare system. And I think that the partnership with an infection prevention control specialist here, when you bring some of these items into your quality and safety agenda at your hospital, is very crucial. So, want to highlight some examples from the UK. The SUSQI project from the Center of Sustainable Healthcare in the UK talks about an equation, and it's not a mathematical equation, but it really depicts well how for each project you could show environmental, social, and financial impact or financial savings together, as opposed to your usual just financial savings. So how do they do that? Let's talk with some examples. So here's a simple project that they did, and the project goal was that they wanted to switch all the IV metronidazole or flagyl, it's a antibiotic we use very often, to convert to oral. So they said, we're going to try as much to get all our patients who are using the IV form to use the oral form of the same medication, which we know is absorbed well orally. So when they did that, and I love how they depicted it, they said 5 days of IV flagyl is like driving 80 miles, whereas 5 days of oral flagyl is like driving half a mile. And then you put it into perspective, because they also looked at how that would benefit the patients. So the social impact, because it's going to be fewer IV infections, reduce discomfort, because nobody likes to be attached to an IV pole. And then 7,900 nursing hours were saved by doing this, which is a lot of time. Think about how they could channelize this time into your hospital's other quality and safety priorities. And then, of course, the carbon reduction, because by the process of manufacturing, transport, and storage, IV medications are much more carbon exhaustive than oral. So this is how they depicted everything together in on one page. And I think it's very impactful, and we could use it in some of our projects. So similarly, streamlining birth and suture packs in maternity care. So they replaced 10 single-use instruments with reusable instruments. And of course, it improved care and no change in clinical outcomes, carbon savings, and then $27,000 or pounds per year saved, and then social impact as well. So for each project, they use this template, which we really like. Another example I want to give was a project that we did at our hospital where we said, by consolidating multiple physician visits, you can save a lot of emissions. So in our long COVID clinic, the patients see multiple providers together, and we calculated how many trips they would save by thinking about how many specialists they are seeing at each visit. And then you can depict that in various ways. So for people who are having trouble understanding what is the meaning of these many carbon dioxide equivalents saved, or those who are not familiar with carbon metrics, you can display it in miles, but also in terms of like trash bags or smartphones charged. So I have found that med students and residents are really interested in these kind of projects and depictions. And then a little bit about diagnostic stewardship, because you want to order the right test on the right patient at the right time to get the best outcomes. So some examples there, and I heard that Ethan said you are going to talk about this in a couple months. So the Choosing Wisely Canada climate resource, the page has a lot of recommendations on each specialty and what they can do to reduce low value care testing. So I highly encourage you to check that out. And another example is again from our friends in UCLA. So they looked at plastic waste from urine analysis and urine cultures, and they weighed all the supplies that go with every culture. So recently, actually, I also shadowed our microbiology lab to see what all goes. And you will be surprised how much time and energy and how many single-use consumables go into getting us that one culture result. I think that's a great project for any med student or resident, just as an activity. Just give them a day to observe everything in the microbiology lab, or the chemistry lab where they do the blood tests, and ask them to write down how many consumables are being used, and just do it like an observational study. I think it would be great. So in their study, they looked at urine analysis and urine culture waste, and from the 45% unnecessary testing that was done, they calculated it to be equivalent to driving 335,000 miles and lots of plastic waste. So it's a very powerful depiction. And then this was done from Dr. Jaggi's study where, they calculated different cultures and converted it into miles by weighing all the supplies. And we really encourage all clinicians to think about how, especially with respiratory culture, sometimes we might be over ordering these tests. So if the patient does not have a clinical change requiring a respiratory culture, perhaps we can avoid that. Because for them, for example, each positive culture, as you see, each positive ET tube culture was like driving about half a mile. Negative ET tube cultures is like 0.2 miles. So it may seem like a small number right now, but we're talking about really large hospitals, 300 bed, 600 bed hospitals, and all these cultures and waste does add up when you think about it. So what are some ways to reduce plastics in healthcare? You can do some simple auditing. Just think about what all is going into the trash can. So by auditing and leveraging data and building circularity. With respect to microplastics, we already know that microplastics are seen in pretty much every organ of the body, from the brain to the heart, and they are really pervasive, can cause oxidative stress, inflammation, and organ damage. So we should try our best to reduce single-use plastic consumption in healthcare wherever possible. Sorry, I'm just going to look at the time. So a simple example of that was at the OHSU, Dr. Guzman did a study where she replaced the single use and throw stethoscopes with reusable ones, but made sure that they're high touch surface area, so they're cleaned very well, and that way also kept the infection rates low or the same, so there was no impact on that, but saved a lot of mass from going into the trash or landfill, because with every admission we're using more stethoscopes, and honestly you can't even hear that well, on some of those stethoscopes. I feel like that's a complaint I hear very often. So I tell all the trainees that it's really rewarding to build something new, and anyone with passion can become an expert. And doing work in sustainability really helps foster collaborations across the globe. So it's very interesting. And then I know that not all of you may be in ID, but I think you can use this case to advocate for people to get into your specialty as well. So I tell trainees that we pick ID because we like to think of people in in a multi-systemic way, as opposed to just a single body part. We like complex problem solving, soft leadership skills, public health connection, quality improvement. So and we're really progressive as a field in infectious diseases. So I think that you can make a case to your own trainees to pick sustainability as a focus, no matter what they're doing, because of all these considerations. And that can happen through QI, through research, through advocacy or medical education. And that would result in more savings and a better future for children. So if I had to put all the benefits of sustainability on one slide, savings, work hours, simplifies operations, quality safety, makes your supply chain resilient. Patient satisfaction also, there are some surveys that show that. And multiple surveys show that it helps in employee both recruitment and retention, which is a huge problem for hospital admins. At the end of the day, we're all answerable to our community, and it helps build goodwill in the community as well. So I think there's so many advantages of healthcare sustainability, which we're not leveraging enough right now. Lastly, so as Preeti mentioned, we are using sustainability as a tool for recruitment in infectious diseases. And I'm aware that maybe some other specialties are also starting to do that through either disaster medicine or other tracks, through climate diplomas, etc. So the younger generation is the most impacted by climate change, and then they also want to do something to mitigate it. It's going to impact them the most. So having a track in sustainability, one adult ID and one peds ID program have already started doing that, and we're also seeing more integration into the curriculum for med school and residency as well. So I think all in all, our take-home message is that without reinventing the wheel, there are many projects you could do in your own field, QI, research, any of those. But you can start small and publish those environmental savings, because there's a huge opportunity for publications there if you look at financial, social, environmental savings. And you can help us build a culture of healthcare sustainability across the globe, providing high value care to our patients. With ABP, so American Board of Pediatrics, MOC as well, Dr. Patel, who many of you may know, has worked very hard to get it integrated into the question. So I think that's a big win as well, to integrate this into the system. I'm going to skip some of these, and then just to give you a little bit of background, we started this group called Sustainabil-ID. So it sounds like sustainability, but has ID in it, in 2023, and have really grown over the past 2 years. and it's like a wonderful group of people. Here are some resources. So we have a very extensive resource hub on our website. Please check it out and join us if you are interested. This QR code is going to take you to the SUSQI in the UK, which also has a lot of resources on projects. Here is the calculator EcoRx choice that helps you compare antibiotic regimens that I mentioned. And then lastly, this is our collection of infectious diseases and sustainability articles on outpatient practice, how to reduce lab medicine waste, infection prevention, lots of articles on that. So I will put this page on again during Q&A. But wanted to end with this quote and a picture of my twin nieces that says, "We don't inherit the earth from our ancestors, we borrow it from our children." And in many ways, that's what motivates us to, keep working in this field together. So we are happy to take any questions. And thank you so much for staying on.
Thank you both for a really amazing talk. I always enjoy hearing you speak, as it really gives me some sense that there are so many small little incremental changes we can make that end up making a really big difference in both reducing the waste and carbon emissions associated with the care we provide. The first question I have for you is just why do you think it is that infectious disease is the only specialty that has done this stewardship work in the past, which, like you pointed out, I mean, I never had thought about it, really translates into sustainability. Sustainability and stewardship are very linked. Why do you think ID is the only specialty in healthcare that's doing this?
That's a great question. I think what happened was, what I see is that there were some national efforts by actually infectious disease providers saying, hey, we need to, 35,000 people are dying of antibiotic resistant infections each year. We need to start working on this because we're not gonna have enough drugs. And especially at that time, there were really few drugs coming in the pipeline. So there was a White House summit in 2015 about to combat antimicrobial resistance. And then from that, it was they had some goals about decreasing inappropriate antibiotic use. And from there, it was made that it was said that we're going to have antibiotic stewardship programs at each acute care facility. And then that really upcharged antibiotic stewardship efforts, and that we had to have some protected time to do this work in our hospitals. And then now we're, really doing a lot of outpatient. So I think that was the reason that happened, but I don't see any, I think it's, for any specialty I'm sure I don't order every thyroid test properly, or, I need help with some of these things because that's not my area of expertise. So radiology stewardship, I really, really think about radiology. We're not that great in ID and radiology stewardship. We can be better. So we need guidance from our radiology colleagues. So I think that's the reason that it came about, was because we were starting to see such bad antibiotic resistance outcomes. But to your point, I think it should be every specialty.
Yeah, I think the radiologist would have something to say about an ER doctor and stewardship of CT scanning. So I think one thing you guys have both touched on a little bit is kind of how things are a change in medicine, and how this concept is something that's not something I learned in medical school, not something I learned in residency training. And I think there's still an impression in a lot of medicine that giving IV antibiotics is better. And how do you communicate these recommended changes and convince people to make practice change? Because I think, from a patient experience standpoint, it probably is substantially better to be on an oral antibiotic when it's appropriate. But I think there's a lot of uncertainty that it is equivalent or effective to switch to oral antibiotics only. Especially for me, like if I'm admitting someone to the hospital, I feel like I have to have them on an IV antibiotic because they're getting admitted. So they must need an IV antibiotic, right?
I think we can do that through evidence-based medicine and just consulting with the ID physician. Now, I'm not saying we consult ID physician for every single case. That's not what I mean. But what I mean is, for example, for neonates, there isn't enough data that they have good absorption. So maybe for neonates, we want IV antibiotics. For somebody who doesn't have a good gut absorption because they've had multiple surgeries, and have some issue with gut absorption, again, we're not going to recommend that there. So I think on a case by case basis, if we're able to weigh that and use evidence based medicine to guide who would be the best candidate and for whom enteral would actually be better because it would enable them to move around the room, for example, then that would be great because it would help the patient with in both the situations.
There are a couple of things I would just add is we have instituted our clinical pharmacists can do IV to oral conversions automatically if the patient is meeting certain criteria, because oftentimes it can be something that you're just also not thinking about because you're busy as the provider in the hospital. So our pharmacists have a pretty strict protocol about what they cannot do for conversion. And it's not just antibiotics, it's, famotidine and, anti-epileptics and things like that. So that's definitely one area. I do think we need to start addressing this idea that maybe the hospitalization won't be covered by insurance if we don't put them on IV antibiotics. I think we need to put some things in the literature to show our insurance companies that this is in their best interest. Like, it's actually going to cost them less because we can get the patients out of the hospital quicker in many ways. So I think we need to do sort of structure that. And when I've talked with our hospitalists about it, they have to just justify the hospitalization. You may be able to justify the hospitalization even if the patient's on an oral drug. Like for a child with acute osteomyelitis, if the child can't walk and you're trying to make sure they're not bacteremic, you can put them on an oral clindamycin. That's okay. So we just have to make sure that people know what to write. It's not a drop down. It's that I can't send this patient home because they can't walk. That's okay from what I'm told, but it's just something that you have to think a little bit more. If you just put it's IV antibiotics, that's justifying the hospitalization. It's kind of like not as much thinking, but you just need to put in a little bit of thought in the justification for the hospitalization.
Yeah, and I mean, I think we have an IV to PO substitution, but I think pharmacists have been reluctant to use it for fear of stepping on physicians' toes. And I think I have always tried to communicate with our ER pharmacists that my toes are there to be stepped on. And a lot of the reasons I'm ordering IV antibiotics are because the click button is there for it, not because I know it's the right thing to do. And again, a lot of the changes that come with patient management are not things that we get continuous education about. So, if it's equally effective to use oral amoxicillin as opposed to IV ampicillin, I may not know who the right people are for that, but I also have 2 pediatric infectious disease doctors in our state. I don't want to overtax them by calling them and asking every time, is this safe? But if we have, protocols in our EMR that allow us to make those decisions, or if our pharmacists know and can help auto substitute, I really would like to see that practice be encouraged. I have a question from a climate scientist in the crowd who asks, apart from improving methods to estimate emissions, what are some other trainings or resources climate scientists could reference to better support you in reducing healthcare emissions?
I think understanding what the emissions, if we could get data about how many emissions we save and what does that translate to in some kind of way that we can understand about this public health impacts avoided, that would be super helpful. I think that still some of this is a little bit abstract for us. Especially with anesthetics, I think that would be really helpful too, because that's a big one that, maybe we could say, could we, if we didn't use desflurane in our country, like how many lives saved or how many asthma exacerbations avoided, how many diarrheal illnesses, those kinds of things, which kind of pairs both climate science and public health. So we probably need multidisciplinary ways to answer that question.
Yeah, I think kind of echoing that, what I'm suggesting is we do storytelling in research a little bit differently. So by using data from climate scientists about various things we utilize in healthcare, we could depict our research story a little bit differently. Um, so for example, for the snap trial or the balance trial that Preeti mentioned, if we can compare those side by side and depict the environmental impact through the data that they could bring to the table and tell a story for both clinicians and hospital admin folks, that might be helpful.
I'm going to spin this back into another question for you guys that talks about some data that I'd like to see. Have we seen cost estimates for the impact of emerging infections in different areas? I can only imagine the cost of Lyme coming to my region being astronomical in terms of, disability adjusted life years, productivity loss, the increased contact with patients in care. I mean, I think we have enough tick-borne hysteria when anyone gets exposed to a tick to begin with. But if we're actually seeing disease from it, like Lyme endemicness in New England, or God forbid, something like malaria becoming endemic in the southeastern United States, like, can you imagine what the cost of that to society would be?
Yeah. And
But
coccidioidomycosis also is moving a little bit further towards your area as well. So that's going to be another one that I think is going to be interesting to watch. Yeah. I do think we'd have to get, yeah, we need some public health colleagues here because I do think there's some data on heat right now when the heat is there, and then some data on diarrheal illnesses. But with the infections, I'm not sure we have a ton of economic data on that, which will be
I
very
have
impactful.
I think I've read some preliminary data on how it would impact, sub-Saharan Africa and Asia the most if things continue the way they continue, because these are the regions that are already vulnerable and would be bearing the brunt of economic loss due to climate change. Um, so that I have read, but like specifics related to healthcare, we may have to look. There's also a lot of data on antimicrobial resistance, of course, worsening with climate change.
Changing tack a little bit. I love kids, but I hate math. And I've heard you speak about this before, where we can use, instead of those precise 17.6 milligram doses, that we can use sort of more standard dosing like we use in adults for kids. And that's also a way we can help reduce having to throw away these prepared antibiotics in kids. Is that something you guys are doing in your hospital now? Is there evidence for these more standardized kind of, dosing ranges? Because, I always feel like we get these 50 to 100 milligrams per day for 5 to 10 days. Those are big ranges. I'm an ER doctor. I don't know. I just go in between. And then find a round number that it sounds like that might be right. And, something you talked about with outpatient pharmacy is like, we don't have a lot of knowledge about what the medication bottle sizes are. And that's not in our EMR. Like, do you want to round down to this number so you can give them just one bottle?
There's definitely I call it band dosing. So if you're between such and such a weight, use such and such an amount. At University of Michigan, they're doing this in their OR. They're just using it for cefazolin. They have, 7 different doses of cefazolin that they're using. So that's a great drug. I think another great drug to use it for is ceftriaxone. Because if you're not treating meningitis, it doesn't matter if it's 50 per kilo or 75 per kilo. Somewhere in between there is fine. And then you could prepare a less amount of doses. So we're just starting that process at our hospital for cefazolin in our OR. but we haven't done it for every drug. I do think this is also, my husband does some informatics work, so I told him like if you wouldn't, we have Epic, he goes to the Epic, place. And I was like, this is what we need to do. We need to have it embedded in the EMR ordering process because we don't have it right now, and that can be really difficult. The other way that people are doing this is that you order whatever you order, and they know on the back end when they're in the pharmacy, the staff pharmacist, that I can, up or down round this within a certain parameter that you've already pre-specified. So then the clinician orders whatever, but you've already figured out what they're actually going to get based on what they ordered. So you can do some basically staff pharmacy changes, or you can do some ordering changes.
Okay, we're at 1 o'clock. I want to be respectful of people's time, but I have two other questions I want to ask. One is from Ashley, who is an infection preventionist with us. Do you have examples of projects you've collaborated on with your infection prevention teams?
Do you want me to take that, Shreya, or do you want to do that one?
You probably have more examples. I
Okay.
have a very quick one where we basically removed double bagging with plastic bags in the tube, the carrier tube system that goes in the pneumatic tube transport, and we had like very specific recommendation when you should use bagging and then when you can remove that excess plastic use. But please probably has some.
The one that we're doing right now is our pillow project, where we're going to go from non-throwaway pillows to reusable pillows. So we did a lot of polling about what other hospitals do. We figured out, we did observations about how the EVS worker was cleaning. We tried to make sure. We haven't ordered a lot of pillows yet. We've only ordered some prototype pillows because we want it to be as easy as possible for that. Like, it has to be able to withstand bleach. It has to be able to, we wanted to use the same wipe as for the mattress in our hospital so that they wouldn't have to use another wipe. And then we had to figure out where to put them. Is it okay if there's extra pillows to go back into the clean utility room? So we were working on that. So that's still a work in progress. That's probably the one that I can think of the most. The one that I think is the lowest hanging fruit with infection prevention is just working on using gloves wisely. That can be something that infection preventionists can be very, very like they can do a lot of education about when you need personal protective equipment and when you don't need it. So that can be very helpful as well. We're doing a paper that should be coming out pretty soon about using gloves wisely. That'll be out in ASHE. So hopefully that can give a little bit of help in that area as well. So just those kinds of very basic things, I think, is where I would start. And there's a lot of things that we do that don't have anything to do with infection prevention, like the toothbrushes we distribute and the bag we give the patient. So those have actually nothing to do with actual clinical care. So at our doctor's dining area, we do not have water bottles anymore. We have reusable plates now. And so like everybody that had the clamshell and throwing it in the garbage. So that didn't actually have anything to do with patient care. And that can be a very low hanging fruit because there's not going to be the dangerous aspect of it. I'm not going to go and do the duodenoscopes right now here. This is really basic stuff that's not going to be harmful.
Well, that leads me to the last question I wanted to ask was, we're throwing away pillows at the hospital. How many pillows are we throwing away? Is this every hospital doing this? This is like standard practice. I mean, there must be landfills worth of pillows from every hospital, like one patient, one pillow, and then they're thrown away.
Yeah, I think there's some variability in practice. I'd be interested to see what you guys do. A lot of the ERs that I've talked to don't have pillows for the patients. I don't know if that's what you have, Ethan. Do you have pillows in your ER?
We have some pillows. Sometimes it seems like they're like a special treat that only shows up every once in a while, and like patients always ask for them, and I never have one to give them.
Yeah, most of the ERs I've talked to do not have pillows, but there's some variability. Some hospitals do have reusable pillows, and some throw them away. So I think there's a cost savings there too. Actually, that would be between $250,000 to $500,000 savings, depending on how often you use the pillow, reuse the pillow. But we have to also put parameters in about when are they going to automatically throw away the pillow. The EVS worker has to do a little extra task in inspecting it and making sure it's not cracked and there's no visible soiling on it. So, it's not easy, but it's something that we can do. So that's been our kind of, we've had a lot of discussions about that.
All right. Well, thank you both so much for an outstanding talk. Really interesting to hear. I always pick up some other project and I'm like, man, we should be doing that. So I hope some of our pharmacists were on this call because I'm coming for you. Let's get some IV to PO substitutions and get kids doing the chewable pills instead of the liquid formulations. So lots of great opportunities for you in your career, whether you're an infectious disease doctor or a pharmacist, an ER doctor, a surgeon, to take some stewardship into your practice. And I think these amazing docs have done a great job leading the way. So thank you for your talk. We'll see you again in April for a conversation about plastics in healthcare with Dr. Leo Tresand on April 8th. So I hope we'll see you then. And please remember to fill out the post survey, and the recording will be up in just a day or two.
Thanks. Great to see you all. Bye.
Thanks for having us.